Hello, wonderful staff of the Northwest Kidney Center. Today we're going to talk about a topic that seems really boring, but is actually very important. The topic is residual renal function. Now, I know that about half of you just closed your browser when you heard that topic. But for those of you who are still watching and are tempted to go back to Netflix, hear me out. Residual renal function is actually incredibly important, probably more important than any other single modifiable factor in determining prognosis and clinical outcomes in dialysis patients. It's more important than the dialysis modality, whether they're on hemodialysis or peritoneal dialysis. It's more important than the dialyzer we use or the dialysate prescription. It's more important than any of the medications we administer to our patients. And that is why we need to know something about it. If you're going to work with dialysis patients, particularly at the flagship Northwest Kidney Center unit in Kent, then you need to be armed with information that equips you to understand this incredibly important concept that can translate into better survival, better clinical outcomes, and better care for our patients. Today's talk has three objectives. I want you to know the definition of residual renal function, appreciate the clinical significance of residual renal function, and finally understand factors that can affect residual renal function. Let's begin by reviewing the functions of the kidney. Kidneys, of course, are very important for cleaning the blood. We call that clearance. Very important for removing fluid in the form of urine, and this refers to something called fluid balance. Kidneys make hormones, including erythropoietin, which stimulates red blood cell production, as well as vitamin D, which is important for our bones. And finally, kidneys are very important for regulating blood pressure. Residual renal function refers to the remaining functional capacity of the kidneys in dialysis patients. So represents the residual ability of the kidney to perform the same essential functions that we talked about, such as filtering the blood or cleaning the blood, so removing solutes such as creatinine and urea. Removal of fluid, we call that ultrafiltration. Production of hormones, some people on dialysis still make erythropoietin and vitamin D. And of course, the ability of the kidneys to regulate blood pressure. So we generally start patients on dialysis when they have less than 10% kidney function, plus some symptoms related to this, such as nausea or loss of appetite or severe fatigue or, say, shortness of breath from fluid retention. So most patients starting dialysis have what we call significant residual kidney function. About 80% of new dialysis patients have somewhere between 5 and 10% renal function, according to the USRDS, and that is a lot of kidney function. Residual renal function is very important for a couple of reasons. One, it's associated with improved mortality. So reduction in mortality, both all-cause mortality as well as cardiovascular mortality. Also, if you still make urine, patients have better quality of life. They have fewer dietary restrictions. They can drink a little bit more fluid. They can make it in between their dialysis sessions without developing shortness of breath. And in general, they oftentimes feel better because their kidneys are still removing some of the uremic toxins that make them feel bad. How can you tell if a dialysis patient has residual renal function? Well, you can just ask a simple question. Do you make urine? That said, making urine does not necessarily mean that the kidneys remove more waste products from the blood. So removing salt and water in the form of urine is just one of the many functions of the kidney. So some people make lots of urine, but their kidneys don't clean the blood well. So just keep in mind that residual renal function refers to not just urine production, but also how well the kidney performs its other functions, such as cleaning the blood. Let's now discuss the clinical importance of residual renal function. There are a couple of essential components to residual kidney function. First is the clearance of uremic toxins, so waste products from the blood. And the second is the removal of fluid in the form of urine. And both of these can translate into better survival. So we'll talk about that later in the talk. Regarding the clearance of uremic toxins, it's important to recognize that even a low amount of residual renal function adds up over the course of the week. So let's say a dialysis patient has only 5% kidney function. This is sufficient to make a significant contribution to the removal of potential urinary toxins, since the filtration is going on 24/7 as opposed to the 12 hours per week that the patient is undergoing, say, hemodialysis. In addition, residual kidney function allows for the clearance of larger molecules, such as beta-2 microglobulin, that are not removed well by the dialysis filter. Even low levels of residual renal function help with the removal of large molecules. So this is a study that looked at patients with just 1 to 2% of kidney function and found that they had significantly lower levels of non-urea solutes compared to those who had no urine output. Possibly even more important than clearance is the contribution of residual renal function to something called volume control. That is how much fluid a person has in the blood vessels. So we know that urine output is an essential function of the kidney. Kidneys remove salt and water. As an example, a residual urine output of just 1 liter per day equates to 3 liters over the weekend interval. This allows patients to drink a little more, to remove a little less fluid with dialysis, which reduces the frequency of cramping as well as intradialytic hypotension. Recall that low blood pressure during dialysis can lead to reduced blood supply to the heart, so-called myocardial stunning, decreased blood supply to the brain, decreased blood supply to your organs, including the kidneys. All of this can impact mortality. The presence of residual renal function increases the chance of survival on dialysis regardless of modality. And we'll talk about this more later in the talk, but just as a sneak preview, for example, there was a hemodialysis study done in Korea, looked at 2,000 hemodialysis patients, and after adjusting for potential confounders, found that the presence of urine output was significantly associated with survival. Similarly, among peritoneal dialysis patients, the CAN USA study found a 36% reduction in relative risk of death in peritoneal dialysis patients who made urine as opposed to those who were anuric. So it's incredibly important for us to do everything possible to preserve residual renal function among patients on both peritoneal as well as hemodialysis and improve sort of endogenous fluid removal through urine volume. Even if urea clearance is small, the urinary volume is beneficial. We'll address survival in more detail later. Let's now look at the effect of dialysis on residual renal function. In other words, how we dialyze the patient probably impacts the rate of loss of residual renal function. For example, the type of dialysis membrane used may affect residual renal function. One study showed that hemodialysis patients who used biocompatible membranes had more residual renal function after 1 year than those who did not. Now, of course, these days we all use biocompatible membranes, but I just bring up this point as an illustration of the fact that the dialysis procedure can affect residual renal function. Another example is the type of dialysate that we use. One randomized controlled trial found that the use of ultra-pure dialysate was more effective at preserving residual renal function at 2 years than conventional dialysate. Now, of course, we use ultra-pure dialysate in our unit, so it's not something that we need to think about, but again, just serves to illustrate that the dialysis procedure can have an impact on residual kidney function. The frequency of dialysis can also impact residual renal function. Turns out that more frequent hemodialysis appears to accelerate the loss of residual renal function. In one study, patients who were dialyzing at home up to 6 days per week had significantly lower urine volume and urea clearance at 4 and 12 months compared to those who just dialyzed 3 times per week. Perineal dialysis also appears to preserve residual renal function better than hemodialysis, at least for the first couple of years, particularly with the use of biocompatible PD solutions and low glucose concentration dialysate. So phrased another way, the loss of residual kidney function appears to occur more rapidly with hemodialysis than with peritoneal dialysis. And this one's shown in a few studies. There was one prospective study of 279 patients on hemodialysis and 243 peritoneal dialysis patients. And they found that the loss of residual kidney function was greater in hemodialysis patients, with those on PD having an average of 30% more or greater GFR at the end of the study than those who are on hemodialysis. So, with all that said, it's reasonable to mention to patients who are preparing for dialysis that residual kidney function is likely to be better preserved with PD than hemodialysis. But it's still not entirely clear if that translates into lower mortality with peritoneal dialysis compared to hemodialysis. One last point, why is there greater loss of residual function with hemodialysis? Probably because we remove fluid at a more rapid rate during the 4-hour session than with peritoneal dialysis. If we remove too much fluid, patients are more likely to develop intradialytic hypotension, and the kidneys then receive less blood supply, which damages the remaining nephrons. Okay, so we've looked at the impact of the dialysis procedure and dialysis modality on residual renal function. Let's now look at additional factors that can affect residual renal function. So moments ago, I mentioned my speculation that the mechanism behind which hemodialysis is harder on native kidneys than peritoneal dialysis is volume removal, so intradialytic hypotension. So it's very important to avoid hypotension during or after dialysis. Low blood pressure, it adversely impacts the heart, the brain, the intestines, and the kidneys. If the kidneys don't get enough perfusion or blood flow during dialysis, then you lose kidney function. This often happens when we challenge the target weight, which is an appropriate thing to do if patients have edema on exam or high blood pressure. But if they don't have extra fluid, then when we try to take off more fluid, then they will become hypotensive. So just remember, it's okay to run a dialysis patient even, that is to not remove fluid, if they have normal blood pressure and no edema on physical examination. Medications can also impact residual renal function, sometimes positively. Diuretics, for example, send a chemical message to the kidneys to pee more, that is, to urinate more salt and water, although they don't increase the removal of urea waste products. Unless urine output is negligible, diuretics should be continued in patients who start dialysis. Loop diuretics, for example, decrease the need for volume removal or ultrafiltration with dialysis. In general, I continue the furosemide until the patient doesn't make urine anymore, and then we stop it. Sometimes we put patients on blood pressure medications called ACE inhibitors or angiotensin receptor blockers, which at least in peritoneal dialysis patients have been shown to reduce the rate of renal function loss. There was a review of 6 studies done published in 2014, which basically showed that the decline in residual renal function was modestly smaller at 12 months in patients who were on either class of medication. Results from small trials of ACE inhibitors or angiotensin receptor blockers in hemodialysis patients are conflicting. A low sodium diet may potentially slow the rate of renal function loss. One study, for example, looked at 62 patients on peritoneal dialysis and found that those who consumed a lot of salt lost kidney function faster than those who were on a low salt diet. The main reason why residual renal function is such an important concept is that it translates into better survival in both hemodialysis and peritoneal dialysis patients. So this is so important. I want to spend a little bit more time of it on this topic by modality, specifically reviewing some of the studies which have shown this finding. First, we'll talk about peritoneal dialysis patients. So the ADAMEX study, famous study, prospective multi-center randomized controlled trial in Mexico, so Adequacy in Mexico study, looked at 965 peritoneal dialysis patients who were followed for at least 2 years. And the objective was to compare mortality with standard dose peritoneal dialysis versus more intense peritoneal dialysis. So again, low versus greater clearance, but they also looked at other factors that correlate with mortality, including residual renal function. What the authors found was that residual renal function was the strongest predictor of survival. If you still make urine on peritoneal dialysis, your chance of dying is 11% lower than someone who does not make urine. And that impact was much greater than all of the other variables that they looked at, including how well they achieved clearance with the peritoneal dialysis. Similar results were seen in the Netherlands cooperative study on the adequacy of dialysis. This was a multi-center prospective observational cohort study of incident peritoneal dialysis patients. And their purpose was to basically look at the effect of peritoneal small solute clearance and ultrafiltration on survival in anuric patients to establish the minimum levels of small clearance, and also compare the impact of various factors on survival, including residual renal function. The study reported a 12% reduction in overall mortality among those who still produced urine compared to those who were anuric, so similar to the Atomic study. Another important study is the CAN USA study. It's a peritoneal dialysis study that looked at the relationship of dialysis adequacy and nutritional status to mortality. There were 680 patients spread out over multiple centers, followed prospectively for 2 years. And they looked at multiple variables that, and they tried to find a correlation between that and mortality. Similar to the other two studies, the authors reported a 12% reduction in relative risk of mortality among those who still had residual renal function. And those who produced more than 250 milliliters of urine had the lowest mortality in the study. So they had a 36% reduction in relative risk of mortality, much greater impact than age, cardiovascular disease, diabetes, their serum albumin, their transport status, their subjective global assessment. Similarly, residual renal function predicts survival on hemodialysis. This is a study of hemodialysis, 114 hemodialysis patients, single-center prospective cohort study who were followed by 2 years, compared mortality of those with residual renal function compared to those without. They defined residual renal function as more than 100 milliliters of urine, so not a lot. And basically, the study included all those who agreed to participate, and they only assessed residual renal function at the start of initiation. What they found was that any residual renal function was the strongest predictor of survival. If you made urine, you had a 65% lower risk of mortality than those who did not make any urine. And it was a stronger predictor than hematocrit, your smoking status, your age, your time on dialysis, urea reduction ratio, the presence of diabetes, sex, cardiovascular disease, or your dry weight. This graph is what we call a survival curve, and it shows on the y-axis percent survival, on the x-axis time. And after 2.5 years, those who still produce some urine, or those who produce urine at the beginning of the study, had significantly lower mortality than those who produced no urine at the start of the study. Another arm of the Netherlands cooperative study, the adequacy of dialysis, was to examine the relative contribution of residual renal function and different measures of adequacy to survival in hemodialysis patients. They looked at 740 incident hemodialysis patients. They were observed for a median follow-up of 1.7 years. This table basically shows the same thing, that the presence of residual renal function was the strongest predictor of all the variables that they looked at that correlated with survival. So it was more important than age or gender, the cause of kidney disease, the albumin, their body mass index, or how well they achieved adequacy with dialysis. And the last study we'll look at is called the CHOICE study. 734 patients from 81 clinics nationally, prospective observational cohort study involving new dialysis patients, and the goal was to determine an association between urine output with mortality, quality of life, and inflammation. At the start of the study, the researchers asked the patients, do you produce at least 1 full cup, 250 mils of urine daily? And urine output was measured, and 42% of patients was found to correlate well with what patients said. These graphs show all-cause mortality when stratified by the presence or absence of urine output. All-cause mortality was lower in those who make urine. Similarly, these graphs here show that those who produce urine at the start of the study have lower cardiovascular mortality during the follow-up period. Okay, now let's review what we've learned. First point to remember is that residual renal function refers to the remaining kidney function in a dialysis patient. So if they still make urine, they still have residual renal function. Residual renal function and urine output are very important to the patient. Better quality of life, there's more flexibility, less need for fluid removal with dialysis, easier to make it through the long weekend, fewer interdialytic hypotensive episodes, less cramping, and by far the most important clinical association is better survival. Many factors can affect residual renal function, including the dialysis prescription. An example of that is rapid fluid removal. If we remove fluid really rapidly in a hemodialysis patient, it lowers their blood pressure. That causes intradialytic hypotension, which leads to hypoperfusion of their organs, their heart, their brain, their intestines, and their kidneys, which in turn leads to loss of residual renal function. Preservation of residual renal function should be a priority for anyone who takes care of dialysis patients. We should minimize fluid removal on dialysis if it's safe to do so. Consider the use of diuretics to promote urine production. Consider the use of ACE inhibitors. And consider less frequent dialysis when patients first start treatment. Okay, time for the monthly quiz. Question number 1, how can you tell if a dialysis patient has residual renal function? That's right, it's a very simple question. Just ask them if they still urinate. Even small amounts of urine production, again over the course of a week, can have a significant impact on the removal of solutes, particularly large solutes, as well as fluid. Question number 2. Residual renal function refers to which of the following? A, urine production. B, removal of small solute. C, preserved endocrine function of the kidney. Or D, all of the above. That's right, it's all of the above. Of course, probably the most important of all of these is urine production, so volume control appears to trump the others. Who has more residual renal function? A, an 82-year-old man on dialysis who makes 200 milliliters of urine per day. B, an 82-year-old man on dialysis who makes 600 mils of urine per day. Or C, I don't know. Well, a little bit of a tricky question. I think a fair answer is either B or C, but I chose C, I don't know. Because remember, there are different features of residual renal function. There is urine production, there is solute clearance, there's endocrine production, etc. So in this case, I think a fair answer is I don't know, although chances are it's the 82-year-old man who makes 600 mils of urine per day. Which is more important, residual kidney function, B, clearance with the dialysis procedure, or C, I don't know. The answer is A, residual renal function. It's more important at predicting survival than dialysis clearance or any other variable. Next question, the following methods have been shown to help preserve residual renal function. A, choosing peritoneal dialysis over hemodialysis. B, avoiding hypotension during dialysis. C, avoiding excessive fluid removal on dialysis. D, use of an ACE inhibitor or angiotensin receptor blocker. Or E, all of the above. Excellent. The answer is E. Final question. Why is residual renal function so important? That's right. Better quality of life, less need for fluid removal with dialysis, resulting in less cramping and less interdialytic hypotension, better survival both for peritoneal dialysis and hemodialysis patients. This concludes the June 2023 in-service for the Northwest Kidney Center. Thank you for your attention. Thank you so much for the wonderful care you provide our patients. This is Andy Borkobro signing out. Until next month, hope you all have a wonderful 4th of July.